have many concerns about CMS's new experiment reimbursing Medicare Part B. That was posted on March 8th of this year, changing the model of reimbursement from what has been ASP, or average sales price, plus 6% for Medicare beneficiaries, to a model of average sales price plus 2.5% plus a flat fee of $16.80 for a small portion of Medicare beneficiaries. Whenever you apply sequester to those numbers, it actually turns to ASP plus 0.86%, plus $16, I think, and 50 cents. And so it's a much smaller reimbursement. I'm concerned first and foremost that any time you try to change the system of care delivery by simply altering drug reimbursement to physicians, that will negatively impact the care delivery system. I say that because we have some evidence there. So United Healthcare had a pilot with Bruce Gould's practice in Augusta, Georgia, and they published that pilot in the peer-reviewed literature. One of the things that they did in that pilot is they did not reimburse for drug utilization, and they had many other system care delivery changes. They thought that if they didn't reimburse for drug use, and there was no financial incentive to the doctor to prescribe higher cost drugs, that total costs of chemotherapy drugs would go down. What they found from the experiment was actually quite different than that. The pilot demonstrated that the cost of cancer drugs actually did go up during the time interval, from $7 million to $21 million. So despite the fact that there were no financial incentives for the doctors to prescribe more expensive drugs, new drugs came to market that were expensive, that were needed to be used for patients. So despite the fact that doctors had no financial incentive to use them, sometimes they used higher cost drugs. So taking away the financial incentive for prescribing did not hold costs of chemotherapy drugs down. In fact, they grew from $7 million to $21 million during that time interval. What did change, however, is the total cost of care was reduced by around $30 million. And it was reduced because of all of the other changes to the care delivery system that were present, because the majority of the healthcare savings was found in reduction in hospitalizations and ER visits. And I think that's a critical point, because when we focus on how to innovate moving forward, it shouldn't be just a blunt instrument impacting one aspect of the delivery system that will have nuclear reverberations against the whole care delivery system. It should be in thoughtful models that really impact the entire care delivery system. You know, CMMI has been very engaged with stakeholders in the development of the oncology care model. COA and other groups have worked on a patient-centered medical home model. ASCO has worked on a PCOP model. So there are other models that really incorporate changes around the system of care delivery that I think would be preferable to a blunt instrument. So that's one concern. The second concern is that presently, if it's applied to all practices, initially this change to ASP plus 0.86% plus $16.50 something, to a second phase, which has reference pricing, value pricing, and loss of copays, you're having this experiment coexist with 100 practices that will be participating in the oncology care model. So how will you even make apples to apples comparisons when you have sort of multiple pilot experiments going on at the same time? I think that's going to be challenging even just from experimental design. So I think that that's problematic. The third thing is, I think that when CMS and CMMI comes out with pilots that they move forward with, oncology is different. Actually, every oncology disease is different. Breast cancer is so different than myeloma, is so different than lymphoma, is so different than lung cancer, that we really need oncology input from practicing oncologists in how to think about these models and not have them sort of airdropped down on us without notice and without stakeholder collaboration in moving forward. And then lastly, I think that if you have a model where you facilitate underutilization, that you won't care for patients appropriately. I think that Medicare beneficiaries will have trouble having access to the right care that they need. They've modeled, CMS has modeled sort of $480 is the break-even point, that if you prescribe a drug more than that, then it could be money losing for a practice. And if you prescribe a drug less than that, then there'll be financial gains for a practice. So you take a drug like immunotherapy, which you know is very expensive. How does that drug get used in this new scenario? I have nothing to do with his treatment, but we've heard about Jimmy Carter having metastatic melanoma to the brain, and I know that he's been a recipient of immunotherapy, and it's my understanding that he told his Bible school class in December that he was in remission. It's wonderful news. Would that treatment still be available to him underneath this new model system? I mean, I think that that's a big question we have to address, because it shouldn't be about inappropriately decreasing utilization or inappropriately increasing utilization. It should be about facilitating appropriate utilization for patients, so patients get the right care they need. And I think that if you look at pathway systems, like in US Oncology, I've led these pathways for breast cancer for the last 9 years. We try to do everything that we can to facilitate appropriate utilization, looking at efficacy, toxicity, and value, looking at the incremental cost effectiveness in comparison to the next nearest comparator. That kind of system can be incorporated into the oncology care model, can be incorporated into the patient-centered medical home, and can be incorporated into models like PCOP. So I think a better path forward would be to move forward to escalating the time period or rapidly approving those models for an advanced alternative payment model, incorporate a system of evidence-based compliance and comparative effectiveness within that overall system of care delivery, and I think you get better care for patients.